So hi everyone, welcome to this student-led journal club and case reports presentation by student Dr. Luchini. I ask that everyone please stay muted for the presentation, and if you have any questions at the end, we'll answer those at the end. So to introduce our speaker, student Dr. Luchini is a third-year medical student completing his rotations in Joplin, Missouri. He is a two-time KCU Student Summer Research Fellow who has completed work in the labs of Dr. White on the Kansas City campus and Dr. Staudinger on the Joplin campus. He has published a study in the 3D Printing in Medicine Journal and has co-authored a piece about COVID vaccinations in the Missouri Family Physician Magazine with Dr. Paulson. He has also published an excerpt in the Missouri Family Physician Magazine about his experience with the Mercy Family Medicine Residency in St. Louis, Missouri during his 2021 externship. Karstan is interested in practicing in rural Missouri and hopes to aid in improving health outcomes for rural Missourians. He's also an avid golfer and is currently learning how to cook ribs, brisket, and chicken on his offset smoker. Sounds really cool. So, Dr. Luchini, the floor is yours.
Well, hello, everybody, and thanks to all who were able to attend and participate today. So this case presentation comes from my time, I think it was 2 months ago now, in the pain management rotation that I did as an elective for my third year. And this is a really cool case. There's nothing super scientific or really like groundbreaking about it. I just think that it's a really cool, newer way to help people relieve their back pain, which is something that a lot of us as we get older are going to start experiencing. So simply titled, this is a minimally invasive lumbar decompression, a case of a low back pain. So at presentation, this is an 82-year-old female who presents to the pain clinic with low back pain on the right, radiating to the right lower leg posteriorly, as well as anteriorly to the right knee, occasionally extending into the foot. The pain has been present for several years and has gradually worsened over the past 6 months. It's a throbbing pain that is always present, but changes in severity. It's worse in the afternoon or evening. It is noticeable during activities of daily living. And she additionally describes a burning sensation in the legs and notices some weakness, which is a big point in the history there, some weakness in her back and thigh. She rates this pain as a 7 to 8 out of 10. This patient's past medical history includes arthritis, depression, acid reflux, or gastroesophageal reflux disease. Her past surgical history includes a tubal ligation, a complete hysterectomy, bilateral intraocular lens implant, and bilateral breast reconstruction. She's also had bilateral oophorectomy, arthroscopic knee surgery, and foot surgery. So pretty significant surgical history. She has family history of depression, diabetes, high blood pressure, renal disease, and other cancers, and she is a retired non-smoker. So review systems quickly. This is the pain clinic, so it's pretty specific to these right here. So she is experiencing decreased activity, mainly things like bending over doing dishes, folding laundry, let's say like quilting, and like for men who have this, like working at a tool bench exacerbates their symptoms. She's experiencing heartburn, but she does have history of GERD. She's got back pain, she's got neck pain, she's got some non-specific itching that really isn't explained anywhere in the chart, and then some tremors she's also experiencing. She is 82, so maybe some early Parkinson's type stuff going on there. Medication-wise, she's taking omeprazole 20 milligrams daily, a baby aspirin, citalopram for the depression, and then supplemental estradiol. So on physical exam, it's pretty benign, to be honest. We are at the pain clinic, so not much heart, lungs, abdominal stuff going on. It's mostly down here in the spine area, MSK complaints. So here she's got normal spinal alignment, focal tenderness over the lumbar spine, consistent over L4 and 5, and L5 and S1. On the facets, on the right side, greater than the left. She's got moderate tenderness at the right SI joint border, positive Fortin fingers test, which is basically taking your index finger and poking on where you would palpate the sacroiliac joint. Patrick's test, which is equivocal, referring to the right buttock and lateral hip. So Patrick's test for the osteopathic students is the Faber's, so flexion, abduction, and external rotation of her hip. She's got moderate tenderness to palpation over the right greater trochanter with vast reproduction of pain today. And that's something that's more like trochanteric bursitis. Obviously, this is a back pain case, but there are multiple like pain comorbidities that exist in this case, and we'll touch on that a little bit later. She's got a positive compression test, and her facet maneuvers equivocal, increasing central low back pain. So that's basically moving those vertebral facets on each other. She's got some arthritis in there, so it's reproducing pain. And I put a dermatomal chart on this physical exam thing to show in her presentation, she's talking about weakness and sensory deficits and tingling over anterior and posterior thigh. And if you look over here on the dermatomal chart, we're talking about multiple spinal segments, and they're sensory nerves, and they're coming out posteriorly, right? So they wrap around the leg. So you can see in the anterior parts of the leg where these sensory motor deficits could potentially come into play, and then even in the posterior. And spoiler alert, I think it's at the L3, L4 junction. So she's going to experience symptoms from that L3, L4 disc, and she's going to have symptoms all the way down into the sacral distribution, because it's so high up and those nerves run together. So I thought I'd include that for completeness sake, and I underlined that. So we're going to jump straight to imaging here, because they are at the pain clinic. They've probably already seen their primary care provider about it. They've probably been sent to an orthopedic surgeon who has done this imaging and also decided maybe they're not the best surgical candidate, or maybe there are interventions that are more suitable for this patient's pain. So right away, this is a T2 weighted MRI. The fluid is very light here, so this is CSF. And I included, this is actually the patient's MRI. I included some anatomy here just so that you can see what I'm pointing to or talking about. Now I just want to check really quickly. Can you guys see my cursor on the screen? Somebody say yes or no.
Yes, we can.
Yes, okay. So basically this is the patient's lumbar MRI. So here's the sacrum. We've got L5, 4, 3, 2, and L1. Right here, this white layer on each side, this is your CSF, and those provide a cushion for the nerves. And then the black, like hazy looking structures, these are actually the lumbar nerves coming down through the spinal cord, or the termination of the spinal cord. This is the conus medullaris, so the termination of the spinal cord, and then down here, the cauda equina, just a little anatomy lesson. And then the ligament that we're talking about that's causing this patient's specific spinal stenosis is this ligamentum flavum, which goes on the anterior portion of the vertebral arches. And so if you can follow these down, obviously there's a few things that, if you have a trained eye, you can see on here, but right here is where we're focused on. This is hypertrophy of the ligamentum flavum at L3 and L4. And this is just probably some specific buildup of like fibrous tissue and scarring from like long-standing arthritis. She is 82, so she's probably been dealing with a bunch of stuff at the same time. And we'll come back to this picture and I'll show you a few more things after a little later in the presentation. And so here is another T2 weighted MRI, but this is a different section. So she's laying down. Over here is the right, this is the left. Obviously, these are the paraspinal muscles, and then this is the vertebrae. This is a few sections above, and I think I really like these pictures. There's a couple slides I'll show you, but I really like these pictures because you can clearly see the white space where these nerves live. And then here's the spinal nerves right here. So there's a lot of room for flexibility. These are comfortable, healthy nerves that live right in here in this space. There's plenty of space for them to move around. And again, for completeness sake, this is the body of the vertebra. There's the spinous process, the transverse processes, and then this is the vertebral arch. And then the lamina, the things that make up the vertebrae. Moving down a segment, you can see how these nerves are starting to become more compressed as there's like limited space. You can see some non-specific things here, like this might be the beginning of some hypertrophy of the ligament right here as well. There's a little bit of arthritis in these joints, but you can see that these nerves really are starting to lose the space in which they live. And then moving down another segment, you can see that there is basically no white. This ligament is completely protruding into the spinal canal, and it is pinching off those nerves. So this is the L3, L4 spot where her spinal nerves are being completely compressed. So this is the spinal stenosis that we're talking about. And then moving down a segment, you can see that it opens back up, and these nerves have a little bit more room to breathe and move around just a little bit farther down. So for assessment, so this patient has low back pain. She's also got a few other things that are more specific on the differential diagnosis that were in her history. The Fortin's finger test for sacroiliitis at the SI joint, so we included that in the differential. This degenerative disc disease in the lumbar spine, that's in the MRI. I'll show you, again, I'll go back to the MRI and I'll point that one out to you. And then she had specific tenderness over the lateral aspects of her hip, over the greater trochanter of the femur, and she actually got injections for this trochanteric bursitis. She got SI joint injections in treatments previous to this mild procedure that she got today. So the plan today is to do the mild procedure, the minimally invasive lumbar decompression. And thankfully, I have a short little video to show you guys on a little bit about how this works. But before we get there, we'll compare it to other forms of pain relief sort of procedures, if you will. So most commonly for arthritis, some of the best things that you can do, obviously, non-steroidals. So your naproxen, your Aleve, your ibuprofen, and then physical exercise is actually one of the most recommended things for arthritis long-term. And then physical therapy. And then moving forward, like I said, injections, which you can see is listed right here, which she got for the sacroiliitis, trochanteric bursitis. And I think she had even gotten maybe an epidural, which is just some steroid in the spinal cord, not specifically in the spinal cord, but around the spinal cord to try to calm down the inflammation in the joints. But anyway, I think she had previously gotten some injections, but there's no hospital stay. Obviously, PT you can do at the clinic. You can exercise, walking around your neighborhood. The injections, you can actually do ultrasound guided or X-ray guided in some sort of operating room. But really, like, you don't stay in the hospital. There's no major complications from any of these. These are just kind of like putting a Band-Aid on, if you will, short-term relief, something that's not going to completely fix, but it'll help, manage the symptoms. And then there's options like spinal fusion, which she has a collapsed disc on her MRI, which I'll go back and show you here in a second. And then there's things like laminotomy, where they take the posterior part of the vertebral arch and they basically either put a hole in it to try to relieve pressure, or to completely take the spinous process and the arch of the vertebrae off, just to give that spinal cord some more room. And this usually requires inpatient stay. You're going to book this patient a room. They're going to have a procedure. They're going to go under general anesthesia. They're going to knock completely out, and then they're going to need years, maybe a full year, for recovery to be able to get back to a baseline that's manageable for them for those activities of daily living. So we've got the least extreme and the most extreme options, but I think this option is really cool, this mild procedure, because the patient literally walks in the morning. Let's say their procedure's at 9. They walk in at 7:30. They get a little bit of medication to kind of calm them down. And then we prone them on a table. We set up a sterile environment. We might give them a little bit of medication to make them not so worried about the scenario. We'll give them some pain medication so that they're not feeling any of the procedures. And then it really takes, Vertos Medical is the company that makes this. And on their website, they're like, in less than an hour, you'll be relieved of your back pain. But realistically, from start to finish, from the time the patient walks in the room to the time the procedure's over, it's really about a 15-minute deal. But it's X-ray guided. You don't really have to stay. And like this says, 80% of people, so 3 out of 4 patients, experience positive outcomes from this. And there's no major complications. Realistically, this incision length is smaller than a baby aspirin. That is a literal thing. It's literally just one small incision of the knife to get a tool in to remove that ligament, and that's it. It's a very cool procedure, and how how easy it is compared to the surgery, and how effective it is compared to the conservative treatments. So again, a little bit more about the spinal stenosis, pain, numbness, and tingling, which are all things that our patient expressed in the history, and then things we found on physical exam. And yeah, so here's this picture. You can see, you know, the depiction of the hypertrophied ligament, but I just wanted to show this to you right next to the MRI, and how like close they really got it. Like, I don't know, I thought it was fascinating how close this artistic depiction of it is. You know, sometimes you don't really get the best artistic depictions in anatomy textbook, but this one's like spot on. And then the next slide is the same sort of thing, but this will be more explaining the procedure. So you can see like they've painted this. So this is the hypertrophied ligament squeezing on those nerves, and then right here, it's like almost the identical thing. She's got a little bit of a disc bulge going on too that's not helping, but really it is this hypertrophied ligament. So the goal of this is to go in, cut this posterior portion of the ligament out, and try to relieve that pain. And so here's the video. Just make sure you adjust your volume accordingly. I'm not sure how loud it is going to come through the screen, but yeah, hang tight.
The mild, minimally invasive lumbar decompression procedure represents one of the greatest advances for interventionalists treating patients with lumbar spinal stenosis, or LSS, with neurogenic claudication. This minimally invasive outpatient procedure offers a safe and efficient means of providing LSS patients with significant mobility improvement and pain reduction. The mild procedure requires no general anesthesia, steroids, or opioids, and removes a major root cause of stenosis while leaving nothing behind, no implants, and no stitches. In LSS, hypertrophy of the ligamentum flavum is common and responsible for up to 85% of central canal narrowing. In fact, a 2-year level 1 study showed that 95% of LSS patients exhibiting central canal stenosis also presented with other contributing comorbidities, and just 5% of patients had central canal stenosis only. Mild focuses on the debulking of the hypertrophic ligamentum flavum, addressing the problem directly. Its safety profile is extremely robust. It has been clinically proven to be equivalent to an epidural steroid injection, with no device or procedure-related serious adverse events or complications reported in any clinical trial. The entire procedure can be performed through a single tiny incision using a narrow, stabilized, depth-limiting portal under still and live image fluoroscopic guidance. The mild bone ronger enables clearance of any obstruction posed by osteophyte growth, providing direct access to the target area. The mild tissue sculptor is uniquely designed to efficiently engage and debulk hypertrophic ligament, allowing for multiple passes before momentary removal and cleaning. Once successful decompression is achieved, the incision can be closed with an adhesive strip, and patients typically resume normal activity within 24 hours with no restrictions. Mild superb, clinically proven safety, efficacy, and durability make mild the next step for LSS treatment after failure of conservative care. To
look for a doctor or find out if a mild doctor's near you, just call this number. But anyway, moving back, I just want to point out something really quickly. When they're talking about, let's see if I can find it. Maybe. Yeah, right there. Give me a second. Anyway, they're talking about protruding discs and other causes of spinal stenosis right here. So disc bulge, facet hypertrophy, and then hypertrophy ligamentum flavum, and then even foraminal stenosis. She didn't have this one specifically, but there were a lot of patients in the pain clinic period that had this foraminal stenosis, and a lot of times the treatment method is the epidural. So just another little pain management interventional tidbit there. But I'm going to go back to the MRI really quickly just to show you some of these other things that she had that were contributing to her back pain. Most of her symptoms were caused by this hypertrophied ligament, but being 82 and having the amount of arthritis that she had, there are just like a lot of other anatomical comorbid pain findings that were on our MRI. So I'll go ahead and I'll go back and show these to you real quick. So actually, I'll show it to you on this one. So right here, so obviously we're at L3, L4. This is L2 and L1, right? So you can see here, one thing that when we're explaining this to patients is we like to point out the big structures. So here's the big bony structures. Here's the, the vertebral column. This gives your back support. And then over here, it's kind of not the greatest part of the slices because you can't really see these spinous processes very well, but these are the bones that you feel if you run your finger down the middle of your back. Obviously, the white is the CSF. These are the spinal nerves. But we look right here and see this black, like oval looking, and then the white in the middle. This is actually the disc. So this is the last thoracic lumbar disc. And you can see it's well hydrated. That's what the white is. White is fluid on T2 weighted, but there's nice fluid in these discs. This one here, right here. But this one has kind of given up and it's starting to push back into that spinal canal. So luckily there's enough room back here for those nerves to just kind of like hang a right and go around them. But this is the degenerative disc disease that was listed in her differential. And a lot of these people actually get on opiates for a long time, depending on who their pain doctor is. But here specifically, like you can see, like this white, the arthritis that's in there, the disc is collapsed. And then eventually these might become like compression fractures. And she might need fusion in these long term, but she's 82. So the goal is like happy life, comfortable life as long as possible without being invasive, because we wouldn't want to put an 82-year-old in a bed in the hospital for 3 days and give him a year of recovery. But I digress. There's another little bit of a disc bulge right here at the L3, L4 that I think is helping contribute to this hypertrophy ligamentum flavum right here. So it's really causing this narrowness. And you saw on the transfer section how pinched these nerves were. So she's got a couple of those bulging discs. She's got degenerative disc disease here, and then the hypertrophy ligament. So a lot going on in that MRI. Just to close, it's hard to show the procedure without it, to be able to de-identify the patient, but these are just like fluoroscopy. Is fluoroscopy guided? So you can see these are all just different pictures. So this is how we're going to find our segment, right? So right here is where the ligament is that we're going to cut out, and basically the fluoroscopy is like using a bunch of X-rays. So an X-ray would be like one picture of a bone, whereas this is like when she's taking the tool in and inserting it through. This is called the trocar. So it's kind of like a guiding tube, if you will. And then there's two tools. There's the bone remover, then there's the ligament remover tool. We use these shutters to kind of focus the radiation here, so that way we can take a bunch of X-rays at one time in order to guide the instruments into the right part, to cut out that bone and make room for the tool to go in, to cut out that ligament, and really just like make sure we're causing as little radiation as possible, because there's minimal risks, but radiation is one of them. But long term, this is really not that big of a player in terms of disease in the long term, but really it's just to focus the radiation to this one spot and to give us imaging for removing this hypertrophy ligament. So I've been paying attention to this patient's chart since the procedure. Her procedure was on my first day. I think it was in September. So like September 1st was her procedure. I was on the procedure where she got the mild done. She literally walked out of the operating place, the hospital, basically. And then 2 weeks later, she had a scheduled follow-up with Katie, who's wonderful at the pain management place, the Pain Institute. But the patient was able to walk without pain immediately after and 2 weeks after this procedure. I thought this was significant. An 82-year-old walking her dog over 1.5 miles. That's how much pain reduction she had. So she went from having the inability to do like daily living things, washing dishes, folding clothes, things like that, to be able to go on, cardiovascular adventures with her pet animals. So huge difference. And then, like I said, she's able to do her activities of daily living again. She's able to live her normal life pain-free after this procedure. So just to close, here are my two dogs. This is my dog Eliza, dressed up as the mailman. This is her Halloween costume. Just because that patient was able to walk her dog, I just figured I'd share it with you guys. My dog. And then this is Sophie. This is my giant German Shepherd puppy. She's like 10 months old right now, and she is awesome. So anyway, just want to say thank you to Dr. Rebecca Sanders at Freeman Pain Institute for letting me use this case. And then again, MSSU KCU Research Consortium for putting on the student-led Journal Club and Case Report series, and Vertos Medical. Even though I didn't link the website, if you go on there, if you're interested in something like this is a procedure that you think would be interesting to you. If you have the correct clinical diagnoses, then you can go on there and learn all about it. But yeah, just thanks to those big three for giving the opportunity today. And I would like to open it up to questions at this time. And I can stop sharing my screen too.
Yeah, I had a question. It's actually about the pain medication they use before they start the procedure. Do you know what they were giving the patients to calm them down, since you said they didn't put them under general anesthesia?
Calm them down. It's like, I think it's Versed, and then based on in procedure, because everybody's pain is different. So we're in the middle of the opioid crisis, so words like fentanyl sounds like pretty scary, but in the right doses and in the right administration, we'd give them fentanyl throughout the procedure. So, and we're constantly checking with them. The Versed knocks them out typically for the entire duration. Like I said, it's about a 20-minute procedure, but as needed, we'll give them doses of fentanyl just to manage that pain and make sure they're not experiencing any of that throughout the procedure.
Okay. And then do you use like lidocaine, like a localized anesthetic at all?
At the site, yeah. So here, I can pull up. Let me screen share
I
again.
might have missed that, but just want to check.
That's okay. I probably didn't mention it. But so like here, so this is like an epidural tube. Can you see, everybody see this okay? At least well enough? Maybe?
Yep, that looks good.
Okay. So like this is like a hypodermic needle for epidural, and we use that to like localize the segment, but we're also using this to like guide the topical anesthetic or the local anesthetic. So it's just like some lidocaine without epi, or maybe, I don't know if it's with epi or without epi, but it's lidocaine. And so basically where we're gonna make the incision and then insert the instruments, we lidocaine the entire track all the way down, and then we're able to work in there, and then it's pain-free. But then again, on top of it, the fentanyl is taking away most of that pain. I see another hand raised. Go ahead.
Karstan, this is Dr. Johnston.
Okay.
I just wanted to thank you for your presentation. Your command of this, not only the video, but your images that you showed were very good, high quality, and you knew your anatomy and your way around the images. So I want to compliment you on that. I want to constructively critique a couple of things when you make presentations of this nature. When you mention the term arthritis, at this age, I think everybody on the screen knows what type you're talking about.
Yeah.
But I do think it's relevant to clarify it by stating from the get-go, she's known to have degenerative joint disease from the get-go. Now, having said that, there's a good list, a laundry list of things that can happen in that age group. And my question to you is that you're very knowledgeable about this procedure and the terminology here. And if the culprit is implicated to be predominantly hypertrophy of the ligamentous flavum in this particular setting, what other procedures does this, what other situations does this type of procedure, is it indicated for? Where else could you use this as a non-invasive or minimal invasive type of procedure? Obviously, this worked, and it was the procedure of choice. But where else is it applicable in this, in other indications for medicine? Where else could you do it?
I think that's a really good question. Specifically, like, Vertos makes this as the lumbar decompressive tool. And a lot of the research I looked at, there's not so much thoracic, there's not so much in the cervical regions of procedures or tools like this. I assume that, anatomically, there are similar structures at all three levels, but I don't know if really any procedures like where there's physically cutting out that ligamentum flavum or, things like that. But there are other pain management modalities, interventions, if you will, that'll help people manage pain. if you're interested in, I can go in depth on a lot of those. This one's
No,
just very.
I'm good on that. I just relevant when I wanted to know more about this MILD, and were there other indications that it could be applicable for? You know, not everybody's got pain, even though they've got bulging disc, and nor does everybody have compression changes like this lady had. So did this lady's distribution of her referred pain correlate exactly at the area that you were operating, L3 and L4?
This lady's specifically, yes.
Yeah.
And you know, it being as high up as it is, you know, you do sometimes experience with these patients, like you'll get sacral distribution symptoms more than you know, like L3 higher up. So yeah, for this lady specifically, it did work.
I did a very nice job and answered my questions very well. Thank you.
Thank you.
Dr. Gordon, you have your hand raised.
Yes, thank you. I'd like to back up a little bit. Could you go like to your first few slides?
Yeah. Let me screen share really quickly. Can you see it?
Yes.
Okay.
All right.
This is the first slide. This is, yeah.
Going. Keep going, keep going. And keep going. Okay, keep on going. Okay, I just want to make sure I didn't miss it. Where's your literature review?
Literature review?
Yes. Did you review the literature on what other treatment options for this condition?
Oh, for this condition specifically?
Yeah.
I don't have one obviously built into my my presentation, but like I said, off the top of my head, there's lots of procedures that we did in clinic that, you know, I was there for a month. I just focused on this one specifically because I thought it was interesting, but yeah, I don't have any other treatment modalities included in this presentation.
Okay, so when one's considering all the different options, first of all, you would consider all the options as a physician, right? You're not just going to focus on one procedure.
Right.
So for example, you would want to look at the literature, and I don't know if it's there or not. I'm asking the question. But
no.
Generally, when one does a case presentation, one does also do a literature review.
Okay.
So what about in comparison, because this is a sort of a surgical procedure that's patented or whatever with this tool. So, what other types of surgical options, in absence of this tool, would one consider as a treatment option?
So I mentioned it like here very, very briefly, you know, not citing anything specifically, but I went over like spinal fusion, the laminotomy, laminectomy, you know, things that she would need like an.
I saw that, but I didn't see, there's like procedures that are done to debulk the bulging disc that are not listed here. And this is
well, it's not a disc. It's not the disc that's being debulked. It's like the ligamentum flavum, like behind, like inside the vertebral arch. So it's this. So like the disc would be here. That was bulging into the canal, but it's really this that was, you know, the side of interest, if you will, on this. But
you did show her imaging with some bulging discs.
Yeah.
Right. And that is a procedure that is done.
Yeah.
Okay. Is there any other procedures besides that would be similar without using this specifically patented tool?
I guess not. I guess not that I'm aware of at this time.
Okay. What non-surgical procedures could be done? Besides PT, you showed that. So physical therapy, injections, what else could be done?
So for pain specifically, or for the ligament? Because there's a way to manage the pain, right? Well, that aren't surgery per se.
This is a surgical decompression.
Right.
Is there a non-surgical decompression option?
I mean, you can give an epidural, and that's what most of these studies like compared it to. But outside of that, I'm not really sure.
I'd encourage you to look up decompression.
Okay.
Okay. So one would, as a physician, one would want to consider all the potential armamentarium approach,
Okay.
non-surgical and surgical. That's what I'd like to encourage you to do. And that's where the literature review comes in.
Okay.
It would be interesting to see the literature just on this. If you could like send us the publications just related to this particular thing, mild. I'd like to see how many trials, if there was any comparative studies.
Okay. Can do.
Thank you.
Mhm.
Dr. Wolf, do you have a question?
Yeah, so I enjoyed your presentation here. I agree with Dr. Gordon, but I was curious. I guess it's my own naivete, but I didn't know that ligaments hypertrophied. So when a ligament hypertrophies, what actually happens there? I mean, I think of hypertrophy as cells getting bigger, and hyperplasia is there being more cells. So when a ligament hypertrophies, what is that really? And so what was the pathophysiology of a hypertrophied ligament?
That's a very good question. And I spent a lot of time trying to understand this. And from my basic understanding, it's more or less that, hold on, I'm not screen sharing anymore. Let me screen share one more time. From my basic understanding, it's that the inflammation over time is building up. And with the facet arthropathy, like up in here, I think over time, this is my assumption. Again, I looked this up and tried to find it a lot, and I really didn't find a whole lot of definitive things, but I think it's just more like deposition of like fibrous tissue after the resolvement of inflammation inside these joints, and just years of inflammation and laying down fibrous tissue over and over again is my basic understanding. I'm not sure if that correctly or completely answers the question, but from my understanding, it's more just that it's like scar tissue building up from the resolved inflammation in this ligament, if you will. Again,
That's what I assumed it likely was as well, but I didn't know that was referred to as hypertrophy.
I think it's more just that the ligament's getting bigger. Physicians can sometimes have language that is just very blunt and abstract, if you will. Ligament getting bigger, ligament hypertrophy. So yeah. Anyone else?
So
No,
that was
there's
great.
there's no law, Karstan, that you can say that this patient is maturing. And with that process of aging, we'll particularly as bones start to compress and canals get more narrower and vertebra start to decrease in size, the canal space is smaller. So to get implied that there's fibrosis and scarring is relatively reasonable. I think Dr. Wolf's comment about at the cellular level, do they actually get bigger? And that's probably not true, not likely.
Right.
Comes with maturity.
Yeah.
Are there any other last minute questions? Well, if not, thank you very much, student Dr. Luchini. That was a great presentation. I really enjoyed all of your images and stuff, and you did a very well job.
Well, thank you.
Thank you.
And thanks, Dr. Gordon, for the criticism. I really do appreciate it. It makes things like this better in the future. So again, thank you for that.